Thank you, everyone.
Thanks, Aguirre. Terrific to be here. Yes, I am a little bit busy. You'll know me as the tired-looking guy on television who every Formula One fan is very angry at today. But lots of infectious disease physicians who have a newfound love for me, so it all balances out. Look, the situation with coronavirus, I think you've seen from me standing up with Dan Andrews and the Minister, is a very significant and serious situation. We have made a point of being blunt and open and transparent about it because people need to know in order to make the plans, and they need to know in order to go through the intellectual and the emotional adjustment for potentially extremely significant disruption. The disruption I'm talking about is the potential disruption because of thousands of cases in the community and what that will mean for our health services, for other residential and aged care settings, disability sector, of course. But also because of the things that we will try and put into place in advance of a really serious situation to try and mitigate the impacts as much as we possibly can. I think you've all seen what's played out in Wuhan, where it was extremely dramatic, but it was a bit distant from us in terms of our connection to it and our understanding of what it would mean for us. And then China, in a quite extraordinary fashion, got on top of it in all of those provinces outside of Hubei province. And now we're in another phase and looking at northern Italy, but then again, 2,000 cases in France and Germany and Spain and hundreds in the UK and more than 1,000 in the US, with it doubling every 5 to 6 days, is a new reality that we will have to come to. We don't want to be in northern Italy's situation where they potentially came to it too late, imposed extraordinary measures that we wouldn't necessarily tolerate here, but that we need to socialise to people now because if we have to impose them, better to do it in advance than to be chasing our tails. I want to take you through some things that I think are do now things that are relevant at a community level, business level, organisational level. That's me. So we have 117,000 confirmed cases globally. It's probably higher than that now after these slides were written a day ago. Over 4,000 deaths. The case fatality rate, so that's the number of people dying over the number of confirmed cases, is 3.6%. Now, there'll be a lot of people who aren't diagnosed, and therefore the true figure is probably below 3.6%. But with flu, we're normally talking about 0.1%. So it's a very different figure. Outside China, and maybe surprising to some, it's quite similar. In Australia, over 112 cases now, 3 deaths. Again, it was 19 confirmed cases in Victoria maybe yesterday. We're up to 28 now. And 4,379 people have been tested negative. We've got about 3,000 tests being taken every day, but only about 1,000 can be processed. That's the global picture. You can obviously see that China's been at the epicentre, but really they're only getting about 20 or 30 new cases per day. They have it under control. They have been over the hump, although for those provinces outside of Hubei province, they need to keep the measures in place in order to keep the numbers down. So they're in for the long haul, and they might be months of those measures and paring them back by increments to see if they can maintain that control. For us, they've almost all been imported cases with a travel history, and they really reflect the hotspots that we've had at different points in time. China initially, but then Iran, the US for Victoria very recently, and it'll be other places in Europe now. How does it compare to other epidemics? So, you know, it's more infectious than some, and it's more severe than seasonal flu and some other milder pandemics like the 2009 flu pandemic. It's contagious enough to have an epidemic curve, as I say, where numbers double every 7 days. I'm happy to make these slides available as well afterwards, so don't feel compelled to photograph everything. And how deadly is it? So historically, the 1918 flu, the R0 is how many people one person infects as an estimate. SARS was 2.2. As you know, it got under control. It took 7 months, 8,000 people were infected, but they got on top of it in large part because people had very severe illness almost across the board. So they all went to hospital. When they realised how you had to look after someone in hospital and protect yourself, they could isolate those cases, they could follow the close contacts, and they got on top of it. MERS, which is another coronavirus in the Middle East, there's been lots of cases linked to handling camels and camel milk and what have you, but it doesn't spread easily person to person, so it hasn't gotten to an epidemic point. And COVID, a bit like SARS, it transmits relatively easily with a shorter incubation period than SARS. You know, it's yet to play out, but it's a pandemic. It's going to go to every country. We're all vulnerable because we don't have immunity. So the lessons learned from SARS is that restricting movements is a good thing, but not just at a town or city level, but at an individual household level. Border restrictions, we think, have bought Australia some weeks, if not months, in terms of the numbers that we're at. So to be at 120 odd now, I think we'd be at 1,000 or more at this point in time if we hadn't had those travel restrictions. And I know they were controversial. We're at a point now where, you know, I think every country in the world probably has cases, whether or not they've identified them, and that there's a really small incremental value in further travel restrictions. You could add the United States, you could add all of Europe, but it'll be South America and other places next. And we already have cases here and local transmission here. So the measures really need to be the social distancing measures that apply across the board because we don't know who may or may not have it. And these are things that will help stop transmission when you can't identify who has it. We know that hospital settings are settings where spread happens more easily, so we really need to protect our healthcare workforce in those closed settings or any other similar closed settings. Aged care has obviously been highlighted as a genuine risk, not just because of the vulnerable population, but because it's a closed setting where people have lots of interactions. So we've got a huge team working on it now. There's over 100 you know, all sectorised in their particular teams to work on plans and the phones and the medical advice, the sectoral liaison, and working across now through the emergency management arrangements, all the other sectors that need to make plans around this space, from the coroner to transport, education, tourism, local government, etc. A lot has been said about 80% of people having mild illness. That's true. I think that's important to recognise. But it does mean that 20% have severe illness. So it shouldn't be compared to the flu, where a lot of people get moderate illness with the flu, but it doesn't kill, you know, 3 in 100, it kills 1 in 1,000. It often has fever and cough, but it could be sore throat or just a runny nose. There's been pneumonia as a key thing in people who have severe illness. I won't go through what we regard as suspected or confirmed. We've now got our health sector plan that's specific for COVID-19, so that's trying to provide some guidance on the phases that we go through. The initial containment that we've been in now, we're really transitioning to a targeted action where we're still doing containment, but we're really ramping up the social distancing messages and measures. At some point we get to a stage where we can't find everyone who's confirmed. We can't follow all of their close contacts, and we stop doing the individual follow-up of cases. We move very strongly to social distancing measures. I'm talking to my colleagues at 12 o'clock around, mass gatherings, all of the social distancing measures that we need to consider. And we're talking about hitting the nuclear button for some of these. Does the AFL go ahead? Do we have any gatherings outside of greater than 500 people? Do we have any gatherings of more than 100 people inside and the like? My view now is that earlier is better. You'll have angry people regardless. There are people who are not ready for those kind of significant social disruptions now because they can't see what the issue is here. But when they can see what the issue is here, we're too late for some of those measures. So I would rather cop the flak for being robust in early measures than saying sorry afterwards because we were too late with everything. But it's a difficult thing. We have to bring the Australian population with us on this journey. I'll skip through these. Subscribe to Chief Health Officer alerts if you want to know the latest, but we've got a terrific landing page on coronavirus on the DHHS website. 90% of callers' questions that we get have the answers there. It's not always easy to navigate. We're trying to make it as easy as possible because there are 1,000 different questions, but go there for a lot of your questions. That's the website address. It's got a guide for health services, but also a checklist, things on personal protective equipment, who needs it, who doesn't, what do you need in different settings, and the kind of posters around social distancing that I've talked about. I might just speak quickly on some of those social distancing measures. So that's everyone washing their hands regularly, carrying alcohol-based hand rub with you if you can find some, having it in the workplace. We need to do that now. Excluding from work is important. If you've got a runny nose, if you've got a sore throat, it doesn't sound like much, but we will progressively, it'll be more likely that those symptoms will be COVID, and we need to practice and we need to have an enabling environment and a policy setting that allows people to stay home. Now that might be working from home if you feel well enough. So we will ramp up and the public sector needs to lead here to have remote working arrangements for as many of the non-critical face-to-face, coal-face workers as possible. Quarantine at home is another thing. If you're a contact of a confirmed case, you'll need to stay at home for 14 days. That might come down. We might decide that it's not 14 days that's required, but at the moment it's 14 days. So making a plan for how you sustain yourself at home, that's getting your online shopping sorted out, online pet food supplies sorted out, any other consumables you might need at home. We've tried to say don't panic buy. You don't need to panic buy. The Groceries Association can support the supply chain, except for toilet paper maybe. But with every shop, have a think about what you think you need for that 2 to 3 weeks of quarantine, or potentially if school closures are extended, or if we've got remote working arrangements for a protracted period of time and you need to minimise the time that you spend outside of home, then an even bigger stock. In the workplaces, as I say, we'll need enabling leave, we'll need really strict monitoring of people who are unwell and the kind of policies that exclude them immediately, and we'll need to implement the social distancing measures for office spaces and for any workspaces starting now, so trying to get that 2 metres between people and reconfiguring spaces so that that distancing occurs properly. Informing yourself will be important about what you need, what you don't need, and not to be overreacting in terms of what's required to protect yourself. So staying up to date with the changing information, and it's been hard for us because we're providing different advice every day because of the changing situation. Grand Prix on, Grand Prix off, that kind of thing. But we'll have to be agile in that space. Other potential social distancing measures might be that, if we get enough people working remotely, public transport won't be super packed. But if it is, it might be about providing a directive to sectors on starting and finishing times, so that you don't have a peak hour crush, but you've got a 6 o'clock start to a 10 o'clock start and people spread out over that period of time. But there might also be significant absenteeism, so it might be on a Sunday schedule or people are anxious and staying away. I can provide a long list of those do now measures. We're going to incorporate them into communications messages, and we'll have them as our ramp up to more significant measures so that people can start to get used to them. I don't know if I should take questions, Aguirre, or... No, all right, thank you.
I know we have lots of questions from the audience. We're going to alternate between a Slido question and then an audience question as well. I think in terms of looking at a Slido question... Sorry? Oh, Kate. Oh, beautiful. Thank you, Kate. So much appreciated.
Yep. We'll kick off with the first question. There's been a couple like this one. Should events or meetings be cancelled? For how long and what size?
I think that's me.
They're all yours, mate.
Yeah.
Right behind you, buddy.
Yeah, so Australian Health Protection Principal Committee, all the chiefs talking at 12 o'clock around this very issue. I note that Ireland, which has 43 cases and a few million people, are looking to have 500 or more as the threshold for cancellation of outdoor meetings, and 100 or more as the threshold for indoor meetings. Other jurisdictions have made it 1,000 across the board, but I think it's a national conversation. It'll be much easier to try and implement if we're providing nationally consistent advice around this and we're all backing each other in terms of what that means. When it happens, again, it's for national agreement. I am prepared to go early if the Minister and the Premier back me around doing this now to save us down the track. So we might be out of step, but I hope not.
Thank you. Any questions from the audience? Sorry, I've got one over there, if you wouldn't mind putting your hand up higher. And then, so I'll go here first. Sorry, third row. Yep, thank you. Then we'll go to Slido and then to there. Thank you.
I'll just say for anyone who's got meetings scheduled, in the next couple of weeks or whatever else, it's your call. It's a greater risk with international visitors at the moment, depending on where they come from. It's a greater risk in an enclosed space. It's a greater risk if there's a lot of face-to-face and close contacts. So, they're some of the principles to apply, and they're in my Do Now notes as well. So you can have a look at those in terms of how you might mitigate meetings that are upcoming.
Shelley Strickland, Watherong Aboriginal Cooperative. This is a child protection question. See you again.
See you again. 2 days in a row.
Exactly. The concerns that we have, obviously, we've got massive concerns around the coronavirus, and we're putting and implementing everything that you guys have been talking about this morning. That being said, obviously our concern is that whilst we have out-of-home care for our children, we have quite a lot of unannounced, for many reasons, to make sure that our children are still safe. That's, part of a requirement by, a judge or a court order. How do we go about doing that? So if we've got them in quarantine and we've got unannounced orders in place, where we need to do visits and so forth, how do we actually continue that so then we ensure the safety of still our children?
Yep. So good question. Beth Allen, if you put your hand up, Beth, some of you will know, Director of Child Protection Policy, will be convening a conversation this afternoon. We talked about those subsector or more deeper dives into the sector planning. That will be one of those scenarios that we will test out. We will apply the information that Brett has given. We will apply the information that Jessie has provided, and then come up with a scenario and some advice that will give our practitioners the sort of guidance about how we go forward with those. We've got to balance here safety, care of children, safety and care of our workforce. We've got to give equal consideration, and again, it will depend, I'm sure, as Brett would say, on the presenting symptoms and issues that are playing out at any point in time, and will have to give us some capacity to scale up and down depending on what those scenarios look like. But again, we will do that planning with you, and they will be slightly different in a home-based care environment, slightly different to a facility-based environment. again, yeah, you're welcome.
Thank you. And next question from Slido.
Again, this one is representative of quite a few questions. So what happens if we can't deliver services or if there's a break to service delivery? Will that affect funding, etc.?
Yeah, so I can absolutely say there is no intention here to disrupt the funding elements of what we put across to our organisations. From a state perspective, it is business as usual. Now, where we reach that threshold and tipping point about not having sufficient staffing resource, we will need to engage in conversations about what the mitigation strategies are. So, Michelle earlier talked about, could we find other sector support that might be able to come into it. We talked about online delivery of fast-tracked input for workforce upscaling and to be able to be shifting the workforce to undertake tasks that perhaps they haven't been able to task. All of these are considerations that we'll take into our planning, and we'll have much more engagement with you on those very issues as we progress through the next coming days and weeks. Andrea, did you want to say anything more on that?
The only thing I will add at the moment, and it's a consideration to the question that was asked of Brett as well, is thinking carefully about the settings that you're sending your staff. So we do know, and an example is that there was a conference that was held, there were some international delegates, one of them was a confirmed case, and that exposed a whole sector's workforce all at once to the disease. So when we think about those mass gatherings or those big meetings, even if you are still considering to attend, and that's okay, you may think about, do we actually want, 3 of our 4 key staff to be attending together? So that's something else that I think is a really practical thing that you can think about right now to try and protect your staff as much as possible, and hopefully lengthen the period of time until we get to the point where we've got to be supplementing staff in facilities.
Thank you. I might just emphasise a point before I go to, there was someone waiting in the audience as well, but Agira, I know we've had lots and lots of questions about funding and people